malady. Come bring some kind melodies. Oh, make myself no do past like this. So many things inside of my jeans. Slide down, libertines, libertines.
Good morning. We are starting. We'd like you all to please, in the front seat, occupy any seat in front of you, so that those who are coming late should be sitting behind you. Please.
just those who can pay for them. And again, no one should be left behind. The second outcome is quality, and that the services not only should be available, but should be of good quality to improve the health of those who receive them. And additionally, the financial risk protection, ensuring that the cost of healthcare does not put people at risk of financial hardship, minimize user fee and out-of-pocket expenditure. These outcomes of the universal health coverage are further emphasized in the Sustainable Development Goals, which Tanzania has commissioned. And this includes the Sustainable Development Goal number 3.7, by 2030 ensure universal access to sexual reproductive health care services, including family planning, information and education, and the integration of reproductive health into the national strategy and program. SDG 3.8 achieve UHC, including the financial risk protection, access to quality essential health care services, and access to safe, effective, and quality affordable essential medicines and vaccines. Again, in the UN high-level meeting, UHC Target 5.6 emphasize on ensuring universal access to sexual and reproductive rights is agreed in accordance with program action of the International Conference on Population and background. Today we'll hear from 6 panelists, very extinguished and conversant in this field, and we'll talk about various strategies and examples from the ground. And I would like now to call our panelists on stage. I'll start by calling out for Dr. Chris Von German, who is a medical doctor and quality officer at the Ministry of Health, Department of Quality Assurance. He's also M&E specialist with several publications in primary health care as well as quality of care. Dr. German, karibu sana on stage. I would also like to call on stage who is a pharmacist that serves as a dedicated supply chain specialist within the Tanzania Ministry of Health Division of Reproductive, Maternal and Child Health. Mr. Mieye has over 80 years of experience with public sector supply chain management and is deeply committed to enhancing national supply chains, guaranteeing availability of vital RMSA commodities to the livelihood. He also possesses Master of Science in Health Supply Chain Management from the University of Rwanda. Machumu, karibu sana on stage. Next on stage in our panel is Adam Rasa. Adam Rasa is a dedicated public health expert, currently serving as a health advisor for ACPO in Tanzania, the British High Commission, Dar es Salaam. He is passionate on strengthening resilient and sustainable health systems for health that are essential to end preventable death and respond to current and future health threats. Adam has worked with ministries of health and development partners in the low and middle income countries in Africa, besides Tanzania. He has also worked in Sierra Leone and supported health programs in Nigeria and Kenya. Adam holds a Bachelor of Pharmacy from Uhuru University in Dar es Salaam and Masters of Public Health from the University of Cape Town. Karibu sana Adam, a round of applause. Next is Dr. Ntuli Kapologwe, the Director of Health, Social Welfare and Nutrition Services at PORALG. Do I need to say more? Yeah, we all know Dr. Ntuli. Karibu sana, and we are very privileged to have you. Okay, next on stage is Dr. Moke Magoma, our country representative from Gender Health Tanzania. He has extensive experience in results-oriented public health and clinical care, with outstanding leadership for over 25 years. His areas of interest include management and service delivery, including RMSAH programming, and over the years he has demonstrated experience in planning and implementation of this WHO, the British High Commission, ESG, UN, and GIZ. As well, he has also worked for the government of Tanzania. He holds a medical degree from Muhimbili and Masters of Medicine in Obstetrics and Gynecology from Makerere, and has a PhD in Epidemiology and Population from University of London. He's also an active member of Agota. Karibu sana Dr. Moke. A round of applause. So now, the one we've been waiting for to balance the equation on stage is Grace Nyoni. Grace Nyoni is Social Welfare Officer at the Ministry of Community Development, Gender, Women and Special Groups. Grace also has past work as a teacher and a social welfare. She has a bachelor degree in social protection and master's degree in social work. Karibu sana Grace, and we are very happy to have you. Grace is also representing Dr. Nandera Mhando, the Commissioner for Social Welfare, who is today on the same day on Mazimisho ya siku ya wazee. So Grace, we are very happy to have you, and karibu sana. So I will start by asking the last person to join the panel a question. Based on the initial introduction that I provided, we talked about equity, and inequity is a major fundamental challenge in actualization of universal health coverage. People with disability, young people, and women face multiple challenges to access services, including and mostly the reproductive and child health services. And that is because on one hand, they have disability, and that might impair their access to service. But again, there are also a lot of stereotypes regarding access and utilization of reproductive health. So Grace, would you share with us what strategies have been put in place by the Ministry of Community Development, Gender, Women and Special Groups to support these groups to access health services, particularly the RMSH services? Karibu Grace.
Development, gender and special groups are entitled to the rights and welfare of the society, special groups like the vulnerable groups such as elderly, children, and so the issues to access the universal health coverage is the right to the affordable social welfare to the national hospital, regional hospital, district hospital are there. That all the vulnerable groups take care of the free treatment. The second is to identify the issues. take them the priority to take the treatment on the health facility. Another strategy that there are to ensure that the implementation of national accelerated action investment agenda for adult health and well-being in a year. This program is multi-sector agenda aimed to empower the adolescent boys and girls to enable them to have sex, reproductive health education, HIV infection, teenagers, pregnancy, professional. And the last strategies are the implementation of the National Multi-Sector Early Child Development Program, the integrated multi-sector program to ensure the children the adequate care and protection that is the and we know that the people with disability are facing a lot of challenges when they go to hospital health. The government set up the structures for them to access the child beds such as delivered beds to the labor
Thank you very much, Grace. A big round of applause. And thanks to the Ministry of Community Development for these initiatives. As we can see, key things that Grace highlighted. So there is free services, free RMNCH services on one hand, but there is also the medical insurance cards on the other hand to ensure sustainability. But also, there are policies that exist. And here she mentioned policies and guidelines like the NAIA, which keeps adolescents at the center, and all priority RMNCH services are integrated, as well as the sectoral policy on children. But most importantly, as we also have people with disability in the room, she also talked about infrastructure, the friendly infrastructure. Thank you again, Grace. And now we'll move to Dr. German, the Quality Assurance Officer. And as we all know, critical to the achievement of universal health coverage is quality of care. Because accessing service is one thing, but the quality of those services should be good enough to first improve the health of that person, the community, but also to guide and encourage people to refer other people to that site that yes, we can get good services in this area. However, evidence suggests that quality of care is still suboptimal, particularly in most low and middle income countries, including Tanzania. So, Dr. Jeremy, as a key implementer from the Ministry of Health, would also like to hear from you what are various quality improvement initiatives that you can share lessons on. What are the innovations that have been put in place? And if you can also talk about supportive supervision and other quality improvements. Karibu, Dr. Jeremy.
Thank you very much, Loretta. Good morning, everybody. As I was introduced, I'm working with the Ministry of Health, Department of Health Quality Assurance. I'm the head of Supportive Supervision Stability. So I'm here to talk the issue of improving the quality of service, especially of maternal child health, especially in the area of supportive supervision. So as you know, the supportive supervision is the key in improving the quality of services in Tanzania and everywhere in the world. So we have supportive supervision has been done in all levels of health service delivery in Tanzania. And as a ministry, we have developed guidelines, and the current one was the one which was developed in 2017 for improving the supportive supervision. But during the implementation, we have some of the challenges, as you know. One of the challenges is there was poor coordination in supervisions. You can see some maybe 2 or 3 people going to the CHMPs without knowing if they have without proper plannings. The other one is there is a use of multiple tools. There was no one tool which can be used across the country, and the other one was issue of follow-up of action items which we are always leaving at the facilities. So as a ministry, we have come up with an innovation of digitalization of supportive supervision in the country. So in 2015, on the 15th of September in 2021, we launched digital supportive supervision, which we call it AFIA supportive supervision, to ensure that the supervisions are well coordinated and we can get a real-time data. So after implementation, the system has been used across the country, almost all the regions, and so in the area of maternal child health, we have integrated the checklists for RMNCH services in the system, and has been used in several regions. And working with gender health, we use the checklist to assess the quality of services in 5 regions of Arusha, Tanga, Pwani, Geita, and Dodoma. Also through the program, the SAF Scaling Up Family Planning Project, we trained the CHMTs and RHMTs in those regions. And last year we trained the RHMT and CHMT in Dodoma region to ensure that they are doing the supportive supervisions in family in the area of maternal child health, also in other interventions in health sector. So that is what we did to ensure that the supervisions which are done are effective and they produce the desired outcome, and also contribute in reducing the maternal and child mortalities. So what I want to add to you is that for all the implementers or the IPs and DPs to use this system, which we and also to support the training of the CHMTs, RHMTs, and the other levels, so that the supervisions are done effectively, and we can track the trend of the supervision which are done, because using the FSS system, you can see who is doing supervision even right now. You can see the council which are doing. But the good thing is that the follow-up of the action plan, everyone who is going to a certain facility or a council at RHMT, you can also track the action plan which I conducted, and it is easy to make a follow-up if the action plan are implemented or are not implemented. So I want to urge all the IPs and DPs to use the after support supervision so that we can improve the practice of supervisions in our councils and in health sector in general. Thank you.
Thank you very much, Dr. German. I think the challenges that he mentioned, every one of us working in the field can relate to. And we've always been asking the ministry, please lead us, please guide us. And another thing that, as implementers, we keep saying, like, now the ministry has utilized these tools, and they keep improving, and the ministry is very open to suggestions on where to improve. And here we have been called, all the IPs, all the can we work together with the ministry to make sure we actually consistently use the government too on the Afya SS. But I think would also like to appreciate all the key important messages that you've talked about regarding supportive supervision, the tools, and the role of engaging the CHMTs and RHMTs in supportive supervision and improving quality care. So now moving to the rest of the panel, primary health care is a driver towards universal health coverage. And that will also support and assist us to improve the coverage as well as advance equity and improving the health system. Primary health care is the whole of government and whole of community. And that combines multi-sectoral policy and action, empowered people and community as well as integrated health system. But additionally, on the other hand, for key health system strengthening, governance, leadership, accountability, financing, and service delivery are vital for universal health coverage. Now to Dr. Ntuli. High-performing and resilient health system built on strong primary health care are essential for UHC and achieving last-mile access of RMNCH services. Dr. Ntuli is a custodian of all RMNCH and nutrition service delivery under PRL, but we also know and recognize you through your leadership and exceptional expertise in PHC. Can you please share with us what are the government of Tanzania's efforts to expand access of comprehensive and inclusive RMNCH services in the last mile? Karibu Daktari.
Services were provided at the secondary and tertiary level. But as I'm speaking to you now, we have 790 health centers, which initially were not providing CMOC services, but now they are providing CMOC services. There's even distribution of CMOC services across the country. This country is quite very diverse. It's a very big country, close to 1 million square kilometers, with a population of 61.7 million people. So what we are seeing now with the UN process indicators, those 6 indicators, 4 indicators are performing pretty well in terms of geographical distribution of our CMOC services, but also the access within 5 kilometers is also performing very well. But apart from that, the cesarean section rate is also within the WHO standards of 5 to 15 percentages of all deliveries. So we have done a number of things which we think that if we continue with this pace, then at least Sustainable Development Goal number 3, it might be achieved before by 2030. That's very important. But also there are a number of innovations. We are working with in gender health, different partners, in trying to make sure that family planning services are available to the women in need. So the unmet need is on decrease. So that's quite very promising. As you know that with the well-accessed family planning, you can avert maternal mortality by 38 to 40%. So with primary health care, having the outreach program, having the mobile services, you can easily reach the women who cannot easily access the family planning methods. And this is a very big plus with the government. But also we have these international and national initiatives, the ENAP, every newborn action plan. Now the government is putting down the number of infrastructure, especially for NQs and other medical equipment to help baby breathe. These are very important things to save the lives of the newborns. But also we have the EPMM, the Ending Preventable Maternal Mortality strategy, which we also adopted from WHO, UNICEF, and other UN organizations. We are also on the verge of actually achieving a number of set indicators within these strategies. But I must say that with all what the government is doing, we cannot underestimate the role of the private sector. We have seen in some of the programs of M-Mama, which is an emergency transportation system, where the government worked with the private sector to make sure that we are using the vehicles which are privately owned to transport mothers and newborn to the healthcare facilities. So all these initiatives makes us think that we need to strengthen partnership and collaboration. We need non-state actors. We need different sectors. For instance, in China, for them to be able to reduce maternal mortality below a single digit, they had one road, one village, one road. And then they made sure that the distribution points for water, safe water, increased. And in so doing, they were able also to reduce maternal mortality. The reason why I'm giving this Chinese example, we need the water sector. We need some other sectors to work with the health sector for us to be able to achieve the last mile service provision. So this is a quite very important theme that and it relates to the primary health care, and it also relates to the core values of primary health care, which is equity. You cannot achieve the last mile without working on the equity, the issue of solidarity, the issue of community orientation and participation, but the issue of social justice, that primary health care is a human right. Everyone should be able to access primary health care. That's why I'm insisting that primary health care is by the people, for the people, including the women, newborn children and adolescents. So we need to work, all of us, for us to be able to realize that. But apart from that, the primary health care, especially the Tanzanian one, is where we have a very good infrastructure for healthcare financing. We have introduced the director's facility financing in July 2017. Now the capacity of our colleagues who are working as frontline workers is very high. The autonomy is high. They can plan, they can budget, they can implement plan, they can evaluate plan, and also they can inspect whatever is happening at the lower level. So capacitating the last mile vehicle, the primary health care, is quite very pertinent as far as the agenda of Sustainable Development Goal and the universal health coverage. I stop there, and I must appreciate being invited to this panel. It's quite very pertinent and also very related to what we are doing at the President's office. Thank you.
Thank you very much, Dr. Ntuli. You know, as we said, you know, PHC is like your second name. You just don't have a passion for it, but we can actually see on your day-to-day activities, publication, etc. You know, one word that you said that will go with me, primary healthcare is a way of life. It's not just anything, it's the way of life. But key thing that he also mentioned and emphasized is the role of partnership. Partnership with the private sector and partnership with the other sectors beyond health. And I think that really calls for all of us in the way we work. You know, when we go to the facilities, when we go to the communities, when we plan, let's also think beyond what we do. But I think another thing that I truly like from what you say, reaching those who are hard to reach. And that's really a core value of inclusion. We just don't expect them to keep coming to the facilities. What do we do to those who cannot come to the sites? But again, also he talked about the capacity. Let us trust our facilities. The capacity has been built. They have means to do things. Let's trust them. Let's give the power back to the facilities that we work with. Thank you very much, Dr. Ntuli, for those comments. Now, I'll move to Mieye. I think it's a common say, and we've all heard that no commodities, no program. We cannot say we run a HIV program without commodities, RMSH program without commodities. And therefore, the role of supply chain in achieving UHC is undeniable. And it's a key foundation to successful healthcare system within a country. So Mieye, can you share with us the overall status of the RMSH commodity availability in the country, and what are the strategies to ensure availability and adequate stock of these commodities to the last mile? Karibu Mieye.
Thank you. Good morning, everyone. By starting responding to this question, first of all, I'd like to describe what are those RMSH commodities. The RMSH commodities are categorized into 3 groups. Products, tenoid. Sorry. The RMSH commodities are categorized into 3 groups, which are the family planning commodities, the maternal life-saving medicine, and the newborn and child health commodities. So for the family planning commodities, as per the Ministry of Health guideline, we have approved the 8 commodities. For the case of maternal life-saving commodities, 3, and for the child health commodities, 2. So coming to the question for the overall status of the RMSH commodities in the country as of September 2023, for the case of family planning commodities, as you know that the government has set the standard for inventory management for these commodities. At the facility level, they have to stock the stock at the 4 months of stock, which is the maximum stock, and the minimum stock of 2 months of stock. And at the national level, the maximum stock level is 9 months, and the minimum stock is 5 months of stock. So having to say that, for the case of family planning commodities, which are 8, about 5 commodities, we have the adequate stock, meaning they are between 5 and 9 months of stock. For those commodities, example, which we are at adequate stock, are like the oral contraceptive pills, and progestin only pills, we have the adequate stock. Also, the other commodities from the family planning, which we have adequate stock, we have the male condoms, also we have the adequate stock, also the medroxyprogesterone acetate, which is an injectable contraceptives, and also the female condoms. For the case of the understock, meaning that they are below 5 months of stock, we have the implants, both the implant on NXT, the 1 loads, and the 2 loads. We have the stock of the uterine devices. So having to say that for the family planning commodities, just in summary, we have 5 which are adequate, 2 understock, and 1 overstocking. For the case of maternal health commodities, the life-saving medicine, which we are considering here, are 3, which are oxytocin, misoprostol, and magnesium sulfate injection. For them, we are in the safe side because we are within the maximum adequate stock for maternal health.
Apologies, Mie. I see mics have some challenges. If you don't mind, you can come and present from here. Thank you very much. As they're fixing.
So for the case of the child health commodities, we have 2 of them, which are the amoxicillin disposable tablet for management of pneumonia for under 5, and the zinc ORS for diarrhea. So for the child health commodities, the amoxicillin DT, we have the adequate stock, and the zinc ORS, we are understocking. So looking at to the facility where the service delivery is taking place, on monthly basis, we have been doing the analysis through our ELMIC system, looking at what is available to the service delivery points. And at August of 2023, the availability of this LMSH commodity overall is at 85%, meaning that at least we are sure that our client, our customer, are getting service. As the moderator mentioned before, that no commodities, no program. So as a government, at least we are sure that our client, our customer, they are getting service to the service delivery points. So coming to the strategies, what are the strategies to ensure the availability of RMSH commodities in the country? So we are the government, we are at the driving seat, coordinating all partners to ensure that they align with the strategic document developed by the minister in collaboration with the other stakeholders. For instance, we have this, the RMNSCH, the 1 Plan 3 document, which is a current document to be implemented for all intervention regarding the RMNSCH service. So all partners working with the government have to align with that document so that to ensure we are planning together, then we achieve all the result as one. So from that document, there are several activities or intervention which are to be conducted. Specifically on the supply chain, we are doing supportive supervision, we are doing mentorship and other coordinating committee meeting. So for the case of mentorship, what we are doing is addressing the challenges for the service providers on how to report and request health commodities from the facility. We know there are some challenges, so we are addressing that by capacitating them on how to fill the ledger, dispensing register, And for new staff, we also orient them on how to report and request the health commodity specifically for the RMSH service through the system called the ELMIS, the Electronic Management Information System. So at national level, we also have this forum called the Commodity Security Committee, which we are doing it on a quarterly basis in collaboration with different partners, supporting the government on the RMSH services. And this forum also has been very fruitful in addressing the challenges of commodity availability in the country. In that forum, we are discussing several issues on the availability of LAMCA commodities, the issue of funding gap, and strategize on how to address the challenge. We also appreciate the support we are getting also from different partners working in the region in collaboration with the PRAG in supporting this initiative of the commodity security. As currently we have the zonal commodity security meeting. To mention, we have been supported by Engender through FCDO to conduct such kind of meeting, and has been very, very fruitful in addressing the challenge of the last mile stock quality for commodities. So another strategy which we are doing is on the issue of quantification. The quantification, we can just say garbage in, garbage out. If we quantify or we mess up in the quantification, we end up having the expiries or out of stock. So the government also initiated several interventions on that quantification. We are currently implementing the bottom-up quantification where the facilities are responsible for establishing the requirement. And we have intervention also like impact approach, whereby the councils, facilities, regions are required to ensure there is data driven for decision making in the supply chain initiatives. So another strategies on ensuring the availability of RMSH commodities is the issue of financing. The financing is very critical in commodity availability. As we see currently, the government has increased the budget for health commodities up to at least 200 billion per year, and even the disbursement for it has been more than 85%, which is very nice for us in ensuring that the service has been provided to the facilities. Also, to sustain the domestic financing, also the government, through the Minister of Waste, has signed a so-called compact agreement with the UNFPA to ensure sustainable financing for RMSH commodities. For instance, for this year, 2023, UNFPA contributed like 2.7 million USD, and the government has to ensure that they also contribute the minimum of 1%, and that has been implemented already by the government by dispersing the 1% as per the compact agreement. Thank you so much. Over.
Thank you very much, Mieye. I think kwanza wote tumekula shule ya commodities and all that. Tukiondoka hapa tunajua systems and everything. So thank you very much, Mieye. And I think another thing that I just want to highlight is the minimum stock. For us, we go to the field and we say out of stock, like out of stock it's already zero. But from here and moving on, we need to know 2 months of stock is the minimum. Like, you know, we're already going to out of stock. So it's important that we all take note of that. But I think another thing that I would just want to, you know, to reflect on is the financing. We see a continuous government commitment in financing health commodities. So the budget as well as disbursement is going on very well, and the compact agreement where, you know, the money which is funded and allocated by UNFPA for commodities, the government is also contributing to that. So for signing that, we know countries have been struggling, other countries have been struggling to sign that and actually actualizing it, but for Tanzania, a progress has already been made. So congratulations. I think we should give a big round of applause to the government for that initiative and commitment. Thank you very much. But that also takes us very well to our next panelist, Adam. You know, as health financing is a core function of the health system that enables progress towards universal health coverage, both by improving effective coverage as well as the financial protection. And development partners use aid as an instrument to assist developing countries to meet their national development goals, including UHC. The role of development partners like the British High Commission towards UHC cannot be overemphasized. As a long-standing partner to Tanzania, can you share with us how the British High Commission is supporting the government of Tanzania to scale RMNCH services in the lens of UHC? Karibu, Adam.
Good morning. So my name is Adam, Health Advisor with British High Commission. First of all, I must say that ending preventable death of mothers, children, newborn babies is one of the top priorities of British government as a whole, but also at the British High Commission. We all understand that every 2 minutes, a woman is dying either by pregnancy or during childbirth. So we seated here like for 40 minutes now. It means 40 mothers have already died. But also we understand every 6 seconds, a child, a newborn, under 5, or a woman dies every 6 seconds. So that's not acceptable. And the bad thing is 70% of such deaths, they are happening in sub-Saharan Africa. And so as a British government, actually we have something to do to change the narrative. So first of all, I want to congratulate the government of Tanzania. Looking at the data that we see from DHS, we see that for the past 10 years, the under 5 mortality has halved, has been reducing for more than a half, which is a good thing. Neonatal mortality has remained almost the same, which means it's an area that we need to work more as a government. But maybe looking at the absolute numbers, it might be decreasing, but still we need to do better there. But also I followed up on the UHI index. We have moved from 38 to 43%, but access to family planning, we scored 63, which is good. Actually, HR for health and the health security, we scored little. That's why we are at 43. So there's a lot that government and partners we are doing to ensure that we are moving in the right direction. So what are we really doing here in Tanzania? First of all, we are supporting a program called Scaling Up Family Planning Program. It has like 2 components. First of all is procurement. We fund UNFPA to procure mostly long-term method for family planning for government. And I think for the past 5 years, we procured commodities worth 64 billion Tanzania shillings. And another component, we work with the partners like in Gender Health and Maria Stops. They provide services directly at the health facilities. And the strength of our partners, they work within the government systems. They train the healthcare workers, they do their outreach, they build capacity there. So our belief is that whatever we are doing, we should not do outside the government system. System strengthening is our core. We don't want to do things in isolation. So we support mainland and we support Tanzania, Zanzibar. But also UK, apart from being the second largest donor for family planning, we are also donating through Global Financing Facility, the World Bank, which is funding also family planning commodities. But also, as Dr. Ntuli said here, we cannot depend on one sector to drive changes. So we are also working with the education sector 89 million pound program that helps young girls to spend 12 years of education. That will help them to become productive members of societies, but also to delay their first pregnancy. Most of these maternal mortalities, they happen for teenagers, all right? So if you give them 12 years of education, automatically they delay pregnancy and good chances to have better outcome as mothers, etc. So we are also supporting education program in Tanzania in that lens. So lessons learned from our implementation, I think I will try to be quick, but I think, first of all, the power of integration. Now our partners, they just don't offer family planning per se. They focus also on screening for HIV, they focus screening for gender-based violence, all right, and they provide support. Actually, when you see the data is very bad, not for Tanzania, globally. For example, 60% of women, they have unconsented vaginal examination. That's a worldwide data. So I don't know for Tanzania, but our programs, actually, they are really integrating that. And when you do integration, one intervention can have multiple outcomes. It is shame for you to go and you just do one thing, you come from Dar es Salaam, you go to my home, Mtwara, I'm coming from Mtwara, and you just do your one thing and you come back. So it's power of integration has made a big impact, I mean, in the health outcomes. But the second thing is coherence. We need to adhere to plan together and work together with the government plans. The good thing in Tanzania, we are part of the sector-wide approach where we sit together, we consult, we make plans together. During implementation, it is very keen that we adhere and we align with the government plans. I went to one facility, I want to mention the region. This region has no enough healthcare workers. One person recruited 5 data entry clerks in a facility where nurses are not enough, doctors are not enough. The government says we need doctors, we need nurses, we need radiologists, but because I have money, I'm going there and I put 5 data entry clerks in a dispensary. So I think coherence, and I'm happy our partners, they are doing that one. I will not talk about joining up with other sectors, Dr. Ntuli has said that, but I think number 4, which I've learned is, I think we need to shift from short-term results, numbers, to long-term impact. When you work with government systems, I'm not promising you that you are going to change things in a single day, but the long-term impact is there. For example, when you strengthen the supply chain, it's not a simple matter, but even when pandemic comes, it's the same supply chain that will sustain outcomes even beyond the family planning. When you train healthcare workers, they will support wider outcomes. They can that's brought now. For this now they can manage well, they can do some monitoring. It's beyond the you are putting. So I think as development partners, normally we like good numbers. So we can buy results, but after the program closes, nothing happens. So I think we need to take long-term, patient approach because the impact will outlast our program. And final point, our vertical program should also address system strengthening efforts. That is very key. If you get money from Global Fund, do whatever you are doing, but ensure that you have a system approach. If it's your family planning, your malaria, ensure that you do you support system-wide improvements. So thank you for listening. Thank you.
Thank you very much, Adam. Thank you very much for those comments, and thanks for the support. The second largest donor for family planning, and we see, investment in various sectors. I would just like, to emphasize on the 4 that you've talked about: power of integration, coherence, multi-sectorial engagement, and the short result number should actually focus on the long-term impact. And I think that also takes us very well to our final panelist, Dr. Moke, who will now put it all together. We've heard from various panelists on various sections and departments. Then let's see how it all comes together as one, as a program, as implementation. So Engender Health is implementing a flagship program on inclusive and integrated RMSH services, grounded on health system strengthening, which is key for universal health coverage. Again, you are recognized as a credible partner to both the government of Tanzania and donor agencies, as part of the panelists have attested. So with your years of experience and through implementing the Scaling Up Family Planning programs, what lessons can you share with us on the value of integration, integrating various health services within the primary healthcare framework and for enabling more efficient and accessible health services? Karibu, Dr. Moke.
Yeah, thank you, Dr. Anna. What should I say more? Previous speakers have more or less spoken almost what I had. It allows me to do some things.
Dr. Moke, excuse me, if you can come here. I see the mics have started to... IT, please, can you fix the mic?
Yeah, thank you. I was saying, what can I say more than what the previous speakers have said? But allow me to add some few issues. Dr. Ntuli mentioned primary health care for the people and by the people. And with that is ensuring that such services are of good quality or high quality, they are equitable, that is inclusive, and through which available financial resources are optimized. Now, allow me to go directly to the Tanzanian context with the reference to the Scaling and Family Planning. We are generously supported to implement by FCDO. Just a few issues to share. We need, as a country, to increase service oversight. That will ensure that services provided to our people are of good quality, and by good quality we mean are safe, effective, with all the attributes of quality. I think I shouldn't emphasize that. We should ensure that essential commodities are there, and through the Scaling Up Family Planning, we had a small budget to procure some essential commodities for this program, but thanks to the joint efforts with the government, PRAG, Ministry of Health, RHMT, CHMT, and the individual health facilities, we have not spent, this is the 4th year of implementation, even a single commodity procured on our part. We have been able to support the health facilities, councils, to do redistribution. You find that one health facility may be oversupplied with the one commodity, while the other doesn't. If there is a good oversight to see the stock levels across the councils and whatever, and redistribute, you may misuse available resources to order additional commodities where you could have used the resources for something else. And another critical issue is ensuring that the essential human resource for health is there. We know as a country, we face a critical shortage of HRH. The country has, Dr. Ntuli, correct me if I'm wrong, it's almost, we are lacking 60% of human resource for health we need. And yet, our people need to receive essential services, especially the RMSH services. We are managing. They have mentioned that maternal mortality is on downward trend, as well as under 5 mortality. However, the decline in maternal mortality hasn't been as fast as expected. Likewise, we seem to have somewhat stagnated on the newborn mortality reduction. but we know what works. Now, ensuring that we have skilled providers in our respective health facilities is key to ensure this. How do you do that? Improve the skills of the available providers. And this can be achieved through various means. You can do task sharing, task shifting of the available service providers to ensure that much as you have the deficit, services are being provided. And I think we can all attest. When we talk to our friends from outside Tanzania and they tell them we have a gap of almost 60% of HRH, people will say, how is that system functioning? And yet we are seeing the wonderful results we are seeing. As a program for the scaling up family planning, we train service providers, those who lack the skills. We orient them through on-job training, as well as in-class training. And through that, we have ensured services are being provided. And we need to appreciate that at times there is a change of providers within these facilities. We may train someone today, after a year or a few months, that person is transferred somewhere to go and do possibly something else other than the essential services you are doing. And because of that, you need to continuously audit the available skills for you to ensure that you are provided the services. And important to all, my colleagues have said integration of services. We do outreach services where we go to remote areas and serve such communities. If you don't integrate, you may go there and just provide family planning services. But will the need really to that community be only family planning services? No. You will only provide a range of services if you integrate. For the scaling up family planning, we do gender-based violence screening, screening for HIV, and linking those people to available services and support, as well as ensuring that there is inclusivity. We know as we go towards universal health coverage, we need to ensure that our services are inclusive. And notably, we have groups within us, which if we are not careful, we may leave them behind. Our colleagues, people with disability, young people, people from disadvantaged geographic areas, or those who are poor, if we are not careful, we are likely to lose them. For the scaling of family planning, we monitor on a yearly basis even the proportion of our clients who are poor, based on internationally prescribed standards, to ensure that we leave no one behind. And particularly, I need to thank the PORAG and the Ministry of Health. You have been wonderful partners to us, always there to guide us what to implement and to ensure that we implement what is required for a people. And to FCDO, words cannot speak. You have been a wonderful partner to us and to our government. And please convey our appreciation for that support. Thank you.
Thank you very much, Dr. Moke. Thank you for that wealth of experience that you've shared in your lessons. I would just like to reflect on the inclusivity that Dr. Moke has talked about. If you are not intentional about programming for people with disability, for different groups in the communities, the young people, you can very easily have oversight. Like if we ask some of the programs that are here, how many of the people that we serve are people with disability? Very few programs actually track that. How many of the people that you are reaching are actually considered like poor in those communities? Because then you could be doing outreach, but you are still reaching the ones who could have even walked to the facilities, who could have paid for services at the private sector. So thank you very much, Dr. Moke, for highlighting that. Now, without further ado, I'll now move the mic back to the floor for questions and comments. Karibuni. Please raise your hands if you have a question, and we'll move the mic to you, Asante.
Okay. Thank you very much. My name is Odageja. Yeah, the first question from myself is, how far have you been connecting people with disabilities to access your services you are providing? For example, the issue of accessibility to get information. Let's say here in my hand, I have a book, but I'm not yet been in a good position to access what has been written in it. How far, by the way, have you been uh, involving these people to access information? And by the second question is the RHC education by itself. Have you been involving these people through associating their organizations? Because every kind of disability, they are in the PD. Thank you very much for this.
Thank you very much. My name is Ricky Nemo. A couple of questions. First comment is Dr. Moke's observation. We need to improve this oversight. That's so I would also want to sort of chip in and encourage involvement, perhaps, of users as well, so the service users. And this could be done in a number of ways, including using means as social accountability, community scorecards, and likes. And maybe we can get a reaction in terms of what the government is doing about it in a way. Then another question to pharmacist Muyeye. You've talked about improvements in terms of financing activities, but I would like to know generally, or more specifically, where are we in terms of needs versus available budgets? What are the needs, current needs for commodities globally here in Tanzania? And what are the approved budgets at the moment? And what strategies then are we using to actually maybe get towards the balancing between the needs and the budget? Thank you.
Thank you very much. Please move to Frederick, and then we'll move to this side. We have a couple of hands from behind there. So if
Thank you.
Please, can I ask the questions to be direct to the point? Thank you.
Thank you. I'm Frederick. Thank you for the nice presentations. I have some few questions, and some of them are comment, actually. Madam, you are talking about the infrastructure, and we see the new constructed infrastructure are taking into account the accessibility needs for people with disabilities. But the challenge, because I've been moving to many places within the country, these infrastructure sometimes, they are not constructed to the standard. You find a ramp very, very steep. A toilet which is meant for people with disability with a narrow door. What are you doing on that? There are measures that you can put in place to ensure that there is a close, monitoring to ensure the infrastructure are really adhering to the international standard. That's one. The second, I think this one is going to be a comment. We know one of the challenge we have with our healthcare providers is lack of skill and knowledge on how to provide inclusive services to people with disabilities. Can the ministry now start thinking about integrating disability inclusive services as one of the topic in the training curriculum for our health professionals, so as to address the challenge? And the last one is on the health management system. The health management information system actually is not clearly capturing the data on disability. I think it's a high time now to review the system and ensure that disability data is captured, because it's very important for planning, for monitoring, and really measuring the impact of our interventions. And lastly, but not least, is the whole, during the opening, The minister mentioned the initiative to really train the community health workers for 6 months. I would suggest that one of the topics that should be covered in those training should be on disability and disability inclusion, because these people are working with people with disabilities who are in rural areas, and many times these are the ones who are meeting them and providing services to them. Thank you very much.
Thank you, moderator and the panelists. My name is Joseph Mweshemi from FHI 360. My question goes to Dr. Germana, who is leading the supported supervision unit. I would like to commend for the great work you are doing in that unit. And as we all know, the ultimate goal of supported supervision is to improve the quality of services. My question is, I would like to know, do we have long-term indicators which shows us where were we for maybe 1, 2, 3 years and where are we now? We know supported supervision is one of the very expensive activity whereby the government is contributing, the implementing partners are contributing, but are we able to measure really the impact of what we are doing? I will give example. One, are we able to tell the patient or client satisfaction rate of those clients who are visiting at our facilities? How about the clinical outcomes? Yes, we are talking about maternal mortality rate. What about the other mortality rates of the services which we are providing in our facilities in the country? How about the adherence to clinical guidelines? Waiting time, are people able to receive quicker services at the moment compared to maybe 1, 2, or 2, 3 years ago? Issues of infrastructure, staff competence and training, availability of essential medication. I'm happy that Mayeye, you mentioned about availability of those medications, resource management and utilization, also follow-up and continuity of care. In 80s, in our history of health services in the country, in 80s, people, we remember service providers used to follow up clients after treatment on their, for example, the patient has been treated on malaria, they can follow up on the community. Are we able to link that with our community healthcare workers? So I would really love to have a glimpse on if we are making any progress on that. And lastly, on the digitalization of supportive supervision. I'm happy to hear about that. It could be maybe focusing more on facility services. What about the community health services which are provided at the community level? Is it integrated in that system or not yet? Thank you.
My name is Mira, and my question is about the resource allocation with the concern about equity. So how are the resources allocated to ensure that the last minute access is improved without compromising the overall healthcare system sustainability and equity? Thank you.
Thank you, moderator and the panelists. I'm John from UNICEF. My question can be responded to Machumu or Adam, and it's regarding the contraceptive commodities. I'm interested to know the proportion of the government contribution to the resources that we're spending on contraceptive commodities, because we understand recently we have seen funding declining from developing countries supporting Tanzania, and of course many other countries. Thank you.
to moderator and the panelists. My name is Dr. Caleb Joel. I work as a system strengthening manager with the MST. And as of our areas of support, supply chain has always been an issue with ensuring the last mile. So for us to, reach the universal health coverage, we need to ensure the last mile is assured. But then the national plans, central pipeline are very good. We heard the numbers from Mr. Mieye that the short term are inadequate numbers. Only implants and Jadel are understocked. But then those which are adequate and understocked are still not available all the time at the facility level for the last mile to access. So the question remains, what are we doing at the lower levels to ensure that the quantification issues, the forecasting issues are actually being curtailed on time? And number two, there's always been an issue with long lead time. Even though the quantification has been done well, and the stock is available, maybe at the zonos, but then it takes so long time for them to be delivered to the facility for the client, for the patient to access them. What are we doing to make sure we improve that, on top of what we've already been doing good? Thank you.
My name is Nyamizi. I would like to direct to the Ministry of Health. Dada Grace mentioned the policy, all child under 5 years get free health. But for those who need more rehabilitation, I suggest to expand that years until he or she. Okay, and the last, this rehabilitation service to increase the service of rehabilitation to those government hospitals, especially municipal or even in the ward hospital or dispensary. We believe that this service of rehabilitation will reduce or eliminate totally the disability for child. Thank you.
Thank you very much. Now back to the panelists. Questions and comments. And I think some comments we've just humbly taken them on board, but I would like to start with the ministry to respond to their questions, and then we'll move on. Dr. Ntuli.
Thank you very much. We had a very good question. Maybe I'll start with the issue regarding the resource allocation. The formula which we are using right now is taking equity into account. So we have resources that are directed to the district, and there are factors which we are considering. There is a population size of the respective districts, then the land captive factor, the under 5 mortality rates, the poverty index, and the hard to reach. So we have added hard to reach because there are some of the district councils which really had. One of the examples is the Ukerewe, where we have 38 small islands within Ukerewe. So you need to have a special formula for that particular district. Then we are done with the resource allocation formula. We go to the facility, and there are factors which we consider there. We have the service utilization rate, we have the catchment population, and also we have included the number of indicators which are maternal related indicators, and OPD and the IPD attendance. So in so doing, we believe we take into account the issue of equity. And then going to a question which was asked by Dr. Mweshemi, indeed, we take into account the issue of community healthcare because the community healthcare system is an extension arm of the primary healthcare. It is embedded within the primary healthcare. So tools which we have right now, we can capture the community, but we can capture the facility as well. So there is no challenge at all. We have distributed number of tablets to the community healthcare workers, and we have the main serve at the Ministry of Health and the President's Office, which has all the information from both the facility and the community. Then with regard to the question which were asked by Frederick, I take them as comment for a government to go and work on. But I must tell Frederick that before 2017, we didn't add any plan for accommodation of the facilities for people with disabilities. And we are very grateful for a number of associations for people with disabilities who we worked with in making sure that we come up with drawings which will be accommodative for the people with disabilities. So the issue of social inclusion is seriously taken by the government of Tanzania. But I also must admit that you go to some other facilities where you find that the steepness of the ramps really, you find maybe there's some technical challenges and other things. So we take all these comments, including the issue of health management information system, and also the most recent are taking the module for people with disability, sign language for the healthcare providers. We have already submitted to the Minister of Education to make sure that the healthcare providers, especially frontline healthcare workers, they should be capacity other things so to attend this. Listen, colleagues respond.
And we appreciate for all the comments, questions. We know we might not be able to answer everything here, but we just hope we will keep the conversation going. Thank you. Okay. So we start with Mie, yeah?
Thank you all for your good question. To start with, I just start responding to the last question about what are we doing to ensure the availability of the RMSH commodity at last mile. Several interventions we have been doing to ensure the RMSH commodity at the service delivery point where service is taking place. First of all, we are doing the mentorship of service providers, including that during audit and reporting, they are not seeking any RMSH commodities. That is one of the strategy we are doing, the mentorship on the management of RMSH commodity. The other thing is the redistribution, especially when the are having the overstocking, and we ensure that we are distributed it to the facility, the out of stock. The ELMI system, the high currently, because people sitting at national level, district level, or regional level can be able to see the available facilities to ensure that the commodities are available at the service point. Of the so, coming to the question of the proportion of what is the government is supporting on the procurement of contraceptive commodities, all understand the very big contribution of government with covering all the storage costs for commodities and also the distribution being covered by the government. As I mentioned it before about the issue of the compact agreement, the government is contributing the 1% of what has been supported by UNFPA. I just mentioned it a few, but it's a lot of contribution. I have not have exact number for now, but the government is contributing a lot on ensuring these contraceptive commodities are available at the service delivery point. So also appreciate the supporting from ensuring the availability of this contract.
Asante sana. Najua bado Dr. German ana maswali ila nitaomba, we would like to respect time. We are at 0. Hatuja over, we are at 0, so we would like to just use this opportunity kuwashukuruni nyote for attending this session, and heartiest appreciation to our panelists for very, very good insights. And thank you all. Karibuni sana. Keep the conversation going. Thank you. A big round of applause, please. Asanteni sana, asanteni sana. Tunaomba group photo. If you can just have a quick group photo with the panelists. A group photo. Naomba mshuke kwa hapa chini tupate a very nice picture. Asanteni sana. Lakini pia kwa sababu tumebarikiwa kuwa na makundi maalum, nitawaomba kama pia mnaweza mkajoin hii picha. Asante. Pictures please. Haraka haraka. Asante, asante. Asante. Karibuni, karibuni. Tunawashukuru sana. And gender health team, please, you can also join the picture. Asanteni sana. Freddy, karibu. Asanteni sana. Tunawashukuru sana for participation. Tunawashukuru for contribution. Thank you very much. Tunashukuru tuna vijana. Scaling up family planning team tafadhali. Dr. Kinema from Pathfinder team tunaomba mjoin. CCBRT tunajua mpo. Asanteni sana, asanteni sana. Our partners, thank you very much. Anapiga pale. Asanteni
Please do not
sana.
leave the room. THPS forum is next.
Asanteni sana.
Thank you very much in gender health. You also kept time.
Thank you very much, Dr. Tool. Always a pleasure. Great. Asante sana. Asante sana. Asante sana. Asante sana.
Hello. Karibuni, please take your seat. Welcome to the THPS Health Forum. May I have your attention, please? Kindly take your seat.
Look.
Welcome, everybody. Please make your way to your seats. Apologies for the delay. The transition in sessions is taking a bit longer than expected. We should be starting in the next few minutes.
Hello, if there is an empty seat in front of you, kindly occupy it. Let us move a little bit forward. Occupy the front seat so that those who are coming late should also sit at the back. Karibu.
Wonderful. Thank you for taking your seats, ladies and gentlemen. On behalf of Tanzania Health Promotion Support, THPS, I'd like to welcome you to our panel on integrating care for non-communicable diseases in HIV prevention, care, and treatment. We're very happy to host you this afternoon. On behalf of THPS leadership, I'd like to welcome you all. Our Executive Director, Dr. Edem Tambatia, had a family emergency, so she was not able to join us this afternoon, but she sends her regards. So as you can see, our panel was to include her, but in her place will be another colleague, Dr. Ola Farid, who will present on that topic. Also, in place of, for TAMISEMI, we have Dr. James Kengia in place of Dr. Chaote. So without further ado, allow me to introduce our first speaker. Dr. Mary Maige is a Principal Research Officer and Director of Research Information and Regulatory Affairs at the National Institute for Medical Research, NIMRI. She has previously served as the Center Manager for NIMRI Muhimbili. She graduated with a bachelor's degree in Medicine and Surgery from Makerere University in Kampala, Masters of Public Health from MUHAS in Dar es Salaam, and a PhD in clinical epidemiology from Newcastle University in the UK. Dr. Mary has also participated in various long-term trainings at various institutions, including the University of Dar es Salaam, Finnish National Institute for Health, Cambridge University, Morehouse College, and Uongozi Institute. Dr. Mary has experience in research, clinical practice, consultancy, focusing on NCDs and the interaction between NCDs and infectious diseases, particularly HIV. Dr. Mary has led various research activities, including the National Survey of NCDs risk factors, Human Heredity for Health in Africa, which is a diabetes project, the Tanzania NCDI and PEN Plus project, among others. Dr. Mary has led and participated in drafting a number of policy documents in the country, including the National NCD Strategic Plans, the National Multisectoral Nutrition Action Plan, the National Health Sector Strategic Plan. She is currently the co-chair of the Tanzania Medical Association of Tanzania National Council and board member of the Tanzania Human Genetics Organization and co-chair of the Tanzania Young Academy for Science. Mary also serves as a visiting lecturer for higher learning institutions and supervises a number of students for masters and PhDs. Dr. Maige has published several peer-reviewed publications, and this afternoon she will talk to us regarding the historical perspectives, current situation, and recommendations on primordial and primary prevention of NCDs among people living with HIV in Tanzania. Please join me in warmly welcoming Dr. Mary Maige.
Okay. All right, thank you. Thank you very much. Do I have a pointer or anything? Okay, I think in the interest of time, I've been thoroughly introduced, so can we please go to the my next slide? So I'm going to talk about the burden of NCD and prevention strategy in general that also applies to in the HIV population. And throughout my presentation, I'm going to give a background of where we are, what is the current burden of NCDs in Tanzania, and highlight the comorbidities that exist between infectious and non-communicable diseases, and what we need to do to expand prevention of, as you said, primordial and primary prevention of NCDs. Next slide, please. This is a slide that I put just to highlight the burden of NCDs globally, and we can see that even at the global level, we are shifting from primarily infectious diseases to having comorbidities that are mostly non-communicable diseases. And so this is the global picture, but we are somehow almost seeing the same things in developing countries. Next slide, please. So this is a slide that I borrowed from the Tanzania NCD strategy, and it highlights the picture that we saw from the first slide at the global level, and it's the same thing that is actually happening also in Tanzania. And we can see that although we still have infectious diseases like HIV, diarrhea diseases, and the like, but we're seeing a shift in the epidemiology of diseases, and we're going more towards, we have diseases that are secondary to infections that are going down, but then we're seeing NCDs actually going up, and I think that is expected with the good work that is being done in HIV programming and maternal and child health. So we should expect also the change in epidemiology, and we have to be aware and make sure that our system is also changing according to the change in epidemiology. Next slide, please. So this is just another slide showing an increase, and this is specifically for cardiovascular diseases, and we can see in developed countries, they have managed to plateau, and now the burden is slightly decreasing, but for developing countries, this is the opposite. These diseases are increasing. Next slide, please. So I particularly like this slide. This is some of the work that we've done. This is part of a report that we did to summarize the burden of NCDs, and it was published in 2020. And we can see that I think the first ideology was that NCDs are diseases of old people, and this is not the case. So we should be aware that we have a huge scope of non-communicable diseases, and these are prevalent across all the age groups. So we can see primarily we have infectious, communicable maternal and neonatal and nutritional issues in the early years, but you can see NCDs are consistent across all the age groups. So when we go to our programming, we shouldn't forget the young ones. They suffer from other NCDs, but we should be aware that that exists. Next slide, please. And so what are the risk factors for non-communicable diseases? We are used to seeing those of us who are working in NCDs. We were initially talking about 4 risk factors and 4 diseases, but we know now that the scope is beyond that, and we have non-traditional risk factors that we're talking about. And some of them actually are to do with nutrition, and some of them, it is beyond the behavioral risk factors that we currently are talking about. So next slide, please. I put this slide just to appreciate the interaction between non-communicable diseases and poverty issues, and as well as access to care issues, and also infectious diseases. And we can see that in your population that you serve, actually this is even more relevant, because you have the population that you serve are more exposed to some of the infection and the inflammatory processes that are ongoing. So we need to be cognizant when we are now intending to go into programming for NCDs within our population, to make sure that we analyze the data that we have and to identify what are the major drivers of the NCDs that you see in your population. You might invest in risk factors that are actually not relevant in your population. So next slide, please. In our population, we know that the current drivers for NCD deaths in Tanzania is actually cardiovascular diseases. But I just want to bring this to your attention that we're actually in the epidemic transition. So we need to focus on cardiovascular disease, but also be aware of infectious causes, but also hypertensive-related diseases, which the main risk factor is actually inadequate access to care. So we might need to also have a look at that before we go to address obesity and all these other causes that are commonly talked about. Next slide, please. So how do we prevent cardiovascular diseases? Next slide. So the primordial, primary, and secondary prevention. I won't dwell into that in the interest of time, but next slide, please. So I just want to highlight this slide. Why do we need to tackle this epidemic from all angles? We need to describe the population that we have and identify the levels of risk factors. And as a primary preventive measure, we need to focus on looking at the entire population, but then we need to have measures to identify those at high risk that are at the far end of the distribution, and make sure that you have individual intervention that targets individual patients according to the profile of risk factors. Next, please. So we might need to implement population-level interventions, but also at the individual level, to have measures to identify those at high risk and address the risk factors, but also the systemic issues, the system issues, to be able to adequately address the burden of NCDs. Next slide, please. So what are the risk factors in Tanzania? This is the data from detailing the risk factors that cause the majority of the burden of NCDs, burden of disease in Tanzania. So we shouldn't just address overweight, or obesity, and physical inactivity, but we also have to look at what risks are actually driving the burden of disease in the country. And when we are talking about risk-based approach, we need to address all that to be able to adequately address the disease burden in Tanzania. And why risk factors are important, we can see all diseases, as the risk level increase in your population or at the individual level, you increase the risk of getting these diseases. So we need to make sure that we shift the entire population to lower risk levels, and in the end, reduce the burden of NCDs in the country. Next slide, please. So this is just to say that we have to take a life course approach. So there are risk factors before even somebody is born. So there are maternal factor, there are environmental factors, there are risk factors that somebody accumulates across the lifespan. So we shouldn't only address NCDs in adults, but also from childhood, addressing nutritional issues, addressing maternal health, and addressing nutritional issues among before conception and all that, and also addressing the food system and the entire environment, because all that affect the risk of NCDs. Next slide, please. So maybe I don't have time to dwell into that, but this is one of the resources, because as I said, majority of the risk, the cause of mortality and morbidity is actually cardiovascular diseases, and this is one good resource that details how the screening can be done, and we might discuss that further in detail. Next slide, please. So this is one of the studies that we looked at the data from our previous national survey. And what it's showing us is that we're actually screening, but we're not screening the people that needs to be screened. And so we need to make sure that we address this in our programming to make sure that we have a good way to identify those at risk and make sure that those identified high-risk population are addressed with the right interventions. Next slide. I would like that to be the last. Next slide, please. So this is just a scoring system. One last slide, and then I'll stop there. Next slide. Next slide. Yeah, so this is our cardiovascular risk profile for Tanzania, but I don't want to go to the next one. Also, we have identified, but then we are not treating the right people. So those that are identified high risk are not the ones that are reached by the intervention. It's talking about the same thing about screening. So I think I'll stop here. We'll have more dialogue. Unfortunately, there was confusion of the timetable, so I'll go and make a presentation in another session, but I'll be back for the Q&A. Thank you.
Thank you so much, Dr. Mary, for that elaborate presentation. The next speaker is my teacher, Professor Kaushik Ramaiah, a member of the board of the World Diabetes Foundation, Honorary General Secretary of the Tanzania Diabetes Association and Tanzania NCD Alliance, President-elect for the East African NCD Alliance, and member of the board of the Global NCD Alliance. Professor Ramaiah served as chair for Sub-Saharan Africa Region International Diabetes Federation from 2000 to 2006, and then as vice president of the global vice president for the IDF from 2007 to 2012. He was appointed honorary professor of medicine and global health at the Liverpool School of Tropical Medicine in November 2018. Professor Ramaiah greatly contributed to a better understanding of diabetes in the African region. He has invested in the status of diabetes care in Africa, the economic costs of diabetes, and its consequences. At present, Professor Ramaiah is working with children who have type 1 diabetes, gestational diabetes, metabolic syndrome, and cardiovascular complications of antiretroviral treatment for HIV, as well as its interaction with TB and diabetes. Together with NIMRI and the Liverpool School of Tropical Medicine, he's working on communicable and non-communicable disease integration models, which is the MONCA study, and will be overseeing metformin interventions in HIV patients with IGT, the META trial. He has also participated actively with other colleagues in several platforms, including the Ministry of Health and TAMISEMI, to implement diabetes NCD program integrated programs at zonal, regional, as well as district hospital levels across the country. This program has now obtained additional funding to expand to encompass NCD prevention and promotion, curative services in primary care, training, policy, and legislations, as well as monitoring and evaluation and operations research. Please join me in welcoming Professor Ramaiah, who will speak to us about the historical perspective, current situation, and recommendations on secondary and tertiary prevention of NCDs among recipients of care living with HIV in Tanzania. Karibu, Professor.
Yeah, thank you. Thank you very much for that introduction. And if I can. Yeah, I was asked to talk about the historical perspective, what's the current situation and recommendation on secondary and tertiary prevention of NCD among the people with HIV. I don't know, what's the flow? Oh, next slide. Okay, next slide, please. So if you look at the background, next slide. This is just to give you an overview of what is happening. If you look at 2003, HIV, people living with HIV were 25 million, well-controlled were less than 5%, new cases were 3 million per year, and premature deaths were 2.3 million. If you look at 2021, HIV, people living 26 million, well-controlled more than 80%, new cases less than 1 million, premature death less than 500,000. Look at diabetes in 2021, 24 million living with it, less than 5% well controlled, 1 million new cases per year, premature deaths about 500,000. And if you look at hypertension, 100 million people living with it, less than 5% controlled, new cases 3 to 4 million per year, premature death about more than 1.5 million. And you can see what has actually happened and what is evolving now. Next slide. So if you look at THD risk factors in people infected with HIV, you have the lipids, which are due to the antiretroviral therapy. You got the age, gender, and family, which is a non-modifiable risk factor. You got inactivity, diet, obesity, cigarette smoking, hypertension, hypoglycemia, and insulin resistance. And all this actually contributes to the risks in people with HIV. Next slide. Yeah, and what you have is, again, HIV infection per se also is supposed to be toxic, and it also causes cardiovascular effect. ARTs with a different form of ART, especially second, third line drugs, might cause you the difference. Currently, with the first line, with the Gravir, I think we have the same issue whereby you get sudden increase in weight, obesity does come in, and if you are not careful with the lifestyle, then you start precipitating other problems. Right? So the concept of what we talk about multimorbidity came from South Africa. This was published in 2015. And if you look at overall multimorbidity, it was around 22.6%, and 94% had more than 2 conditions, and 5% had 3 conditions. And if you look at the clinic in hypertension clinic, you find there were people with diabetes, HIV, and TB who were not diagnosed. If into the HIV clinic, you had patients with diabetes, hypertension, and TB who were not diagnosed. Similarly, in diabetes clinics, you had people with hypertension, HIV, and TB who were not diagnosed, and in TB clinic, it was the same. So this was the first perception of that there is something going wrong with this, and we are morbidity. Slide. So the data which has come in recently, whereby you find that what is a non-communicable disease burden, and if you look at 2015 compared to 2035, in people who are HIV positive and HIV negative, you find that by 2035, we expect more than 50 to 60% of people living with HIV burden. It could be 1 risk factor, it could be 3. Next slide. Again, if you look at overall, what are the NCDs which are very common in people with HIV, you find that there is invasive cervical cancer, there's obesity, diabetes, hypertension, and different types of dyslipidemia. And now even the mental health is being picked up in this patients. Next slide. So, talk about integration. Next slide. So, if you look at integration, you basically, based on the pillars of WHO, you want to look at the service delivery. You want to improve the level of health. You want to improve the responsiveness, adherence, compliance. You need to give social and financial risk protection, and you want to improve the overall quality of care. So when we talk about integration, how are we integrating? Are we integrating NCD into CTC clinics? Or are we integrating HIV-TB into NCD clinics, integrating HIV and or diabetes at a primary care setting? Or are we looking at something else, which includes prevention to child transmission? And next slide. We want to do the integration. We want to do the integration because we want to improve the quality of care. We want to improve the access to care. We want to improve the coverage. We want to make it more efficient, cost-effective, and cost-saving. Next slide. So the linkages between HIV and NCDs. Next slide. So statistics show that in 2019, Systemic Review reported prevalence of depression among people with HIV was 31%. These people with HIV had 2-fold increase in cardiovascular risk factors compared to HIV-negative population. Women living with HIV have 6-fold increase in risk of cervical cancer. Cardiovascular disease is the leading cause of non-AIDS related morbidity and mortality in people with HIV. the global burden of CVD among the people living with HIV has tripled over the past few years, and largely in Africa and Asia Pacific region. And yeah, 86% of them have a premature NCD death occurring in low and middle income countries, and the prevalence of tobacco smoking is much, much higher in HIV positive population. Next slide. So these are the references for all this data. Next slide. Again, within the Tanzanian setting, are we ready to manage the NCD at the primary care? And if you look at this data, this is from the SARA survey, which has been done, and if you see the readiness of these facilities to offer non-communicable disease, you find that diabetes, 54% of the facilities can offer diabetes care, 49% cardiovascular disease management, 42% chronic respiratory disease, and then 72% cervical cancer screening. And that 72% is high because cervical cancer screening is integrated within the HIV and the CTC clinics, and that's why you find that levels are high. So if we are talking about integration, this percentage needs to be improved. Next slide. What are the secondary and tertiary preventions which we can do once we have the integration in place? So if you look at benefits of lowering blood pressure, you find that if you control the blood pressure better, then your stroke incidence goes down by 40%, myocardial infarction by 25%, and heart failure by more than 50%. Next slide. If you look at the benefits of managing this hypertension, then you find that over a period of 10 years, you will actually save 1 person out of every 11 people who have hypertension, and they are basically, there's a net effect which you see over a period of time. Next slide. Again, if you look at diabetes, and if you manage diabetes well, next slide, please. If you manage diabetes well, and if you are able to control, with a good control, with a single reduction of HbA1c, you see that you are actually reducing the peripheral vascular disease by 43%, microvascular by 37%, cataract extraction by 19%, heart failure by 16%, myocardial infarction by 14%, and stroke by 12%. So when you look at the combination of using hypertension and diabetes in a person who has got this multimorbidity, you find that the net effect of saving these individuals from the morbidity and mortality is very high. Next slide. What is the way forward? Next slide. If you look at the cascade of management of HIV and NCD, you're looking at prevention, you're looking at diagnosis, you're looking at enrollment into care, you're looking at management of the disease, and then in terminal cases, you are looking at the palliative care. And if you look at both the sides, I think the only difference is the virus, otherwise the systems are the same. Next slide. So this is the model which we are trying to implement at the primary care, having a common triage, where at the primary care level, as soon as you enter, you actually have your screening done of body mass index, blood pressure, blood glucose, a provider initiative HIV, counseling, testing, and TB. And then based on that, at the health center level, you can do health education, you can go into health education programs, school health programs, community using community health workers, and then going into what we call as a disease-specific services. Next slide. Thank you very much.
Excellent, thank you so much. Next on our list, I wasn't out of time yet, is presenting from THPS, Dr. Ola Farid Jahanpour, a medical professional with over a decade of experience in public health, research, and evaluation, serving as technical advisor for research and surveillance at Tanzania, at THPS, as she also pursues her PhD. Her expertise spans academic as well as implementing partner contexts, making her a valuable asset in advancing healthcare initiatives in Tanzania. She is also a mother of 2 boys and a passionate advocate of breastfeeding, believing that, among other things, it plays a vital role in preventing NCDs. Please join me in welcoming Dr. Ola Farid, who will talk about the burden of NCDs among recipients of care in HIV prevention and care treatments, clinics in Pwani, Shinyanga, and Kigoma. Karibu.
Thank you very much, Dr. Eva. Good afternoon to you. Tanzania Health Promotion Support is a local non-governmental organization that was established in 2011. Currently, we are implementing a number of projects. One of them is Afya Hatua, and I'll be presenting the learnings that we have acquired from project implementation. So, as mentioned, the topic is going to be on the burden of non-communicable diseases among recipients of care in HIV prevention care and treatment clinics in Pwani, Shinyanga, and Kigoma, where Afya Hatua has been implemented. Currently, the program has been extended. We are now in Tanga. Next slide, please. So, earlier this year, THPS leadership set out to integrate NCD services at the care and treatment clinics. We had questions about available data, about the burden of NCD among the recipient of care. We also wondered how integration would actually look like, and also resources that were needed to achieve this goal. Next slide, please. So to achieve this goal, we started with assessing our strength. First and foremost, we were committed to integrate the services. We is the THPS leadership, staff, region and council, health management teams that we work with, and also site providers were aware of NCD screening, diagnosis, and management from their professional trainings. We have established a client flow at the sites, which could easily accommodate NCD integration. Also, we had received the revised CTC2 cards and database, which had included NCD items. And sites had the necessary tools that were needed for weight, heart, and blood pressure measurement. Also, the sites and after our tour had a system to assess the essential medicine that are needed. Next slide, please. So to move towards NCD integration, we engaged with providers, and we also did site visit to understand on the potential challenges. One of the challenges that we identified was negligence. And by this, we mean that some of the providers did not prioritize height, weight, and blood pressure measurement of our recipient of care. Another was the shortage of staff at some of the facilities, and this then made it difficult for the provider to take the necessary measurements. We also noticed there was poor documentation, and by this we mean there was inconsistency between what was recorded in the CTC2 database and what was recorded in the cards. And some sites still had the old CTC2 cards, which missed the columns on blood pressure measurements. And some of the facilities that we visited, we noticed that they were faulty equipments and that required repair or replacement. Next slide, please. So to achieve NCD service integration, the approach that we use, we started to collaborate with experts in the field, some of whom are on the panel today. And next slide. We established a dedicated team to coordinate the NCD efforts. This team received the training. And also, all the THPS technical staff went through an online training on cardiovascular disease, non-communicable diseases. Next slide, please. We also mapped available equipment for the necessary measurement at the sites and ensured that all the sites had the necessary equipment, either by procuring them, repairing them, or redistribution of the available equipment. Next slide. And we also we sensitized the providers on NCD integration and provided the available job aids. Next slide. As early as February this year, we started weekly monitoring of documentation. Does this one work? Weekly documentation or weekly monitoring of documentation of weight, height, and blood pressure. It's worth noting that with regard to blood pressure, when we started off, only 3%, or does not work in the screen. So only 3% of our recipient of care were actually having blood pressure measurement. Next slide. And the regional had came up with the scale-up plans or to improve NCD integration, which included training of the providers together with mentorship and supervision. Next slide. We also integrated NCD across other services, such as the voluntary medical meal, circumcision, and also in other projects that THPS is implementing, such as police and prison. Next slide. And this is our achievement. So for this analysis, we have used data from the CTC2 database, and we have included only adults age 15 and above. And if a person made more than one visit, we took the latest visit. So as you can see, as from March to September, almost all of our recipients of care have their weight measured. Next slide. With regards to height, when we started, almost a half of the clients had their height taken, and as of September, over a quarter of them have their height taken. Next slide. With blood pressure measurement, when we started in March, about half of the clients had their blood pressure measured, and as of now, we are at 90%, over 90% of them with a blood pressure measured. Next slide, please. So, we use the weight and height to calculate the body mass index. As previous presenters have mentioned, this is a risk factor for developing non-communicable diseases. And you can see over 40% of the clients have abnormal body mass index. Next slide, please. And also about 6% of them have elevated blood pressure based on one recording. We didn't do multiple recordings. Next slide. So THPS is really committed to integrate non-communicable diseases in its service. And as a way forward, we are working with CDC to see how to provide antihypertensive treatment to some selected sites as a pilot study. Thank you very much. Next slide.
Thank you so much, Dr. Ola. Now, I have a small treat for you. Next, tuna wageni ambao watapenda kutushirikisha uzoefu wao katika kupata huduma. Kwa hiyo naomba nimkaribishe dada Noela awasogeze wageni wetu ambao wako tayari kusema nasi kwa Kiswahili. Watajitambulisha kwa majina yao na mahali wanapotoka na kutushirikisha. We have two visitors from recipients of care from our clinics who are ready to share with us their experiences in receiving care for HIV as well as non-communicable diseases. Karibuni. Tajitambulisha na kuzungumza kwa kifupi.
Asanteni sana. Mimi kwa jina naitwa Nuruhimu Umari kutoka Shinyanga Mwadui. Mimi niligundulika na hili tatizo mwaka 2009 mpaka kufikia hivi leo nina miaka 15. Na naendelea na huduma, natumia dawa zangu za ARV kila siku na naendelea vizuri. Kwa hiyo na washauri wenzangu, msikate tamaa unapogundulika na hili tatizo, ndio ukajua hivi ni mwisho wako wa maisha. Naomba ukishapewa ushauri na madaktari, utumie dawa jinsi madaktari wanavyokushauri. Ilipofika mwaka 2021 niligundulika na tatizo la pressure. Nilipogundulika madaktari wakanishauri na nikaendelea kumeza dawa mpaka sasa. Kwa hiyo kuanzia mwaka 21 mpaka leo 2023 na miaka 3 natumia dawa za pressure.
Jina langu naitwa Juma Bahingai, ni mwelimishaji rika katika kituo cha afya Uvinza. Niligundulika mnamo mwaka 2000 nilipopata tatizo la maambukizi ya virusi vya ukimwi. Nilipata ushauri wa madaktari, nikaanza ufuasi mzuri wa dawa, ambapo mpaka sasa nina HbL chini ya 20. Mwaka 2020 niligundulika kuwa na sukari, ambapo nilikuwa nikipata kizunguzungu mara kwa mara, nikiishiwa na nguvu mwilini. Nilipoenda kupima wakaniambia nina sukari. Ilikuwa ni 31.9. Lakini mpaka sasa madaktari wamenisimamia na mimi mwenyewe nikijisimamia. Wamemonti mpaka kufikia 7 ambayo nimepima juzi. Nikiwa mwelimishaji rika, zipo changamoto ndogo ndogo ambazo zinatusibu na hasa mazingira rafiki ya kufanya counseling. Kwa hiyo niwaombe wadau wetu kuendelea kutusimamia na kutengeneza mazingira mazuri ambayo tunaweza tukafanya counseling ya mtu na akaelewa kwamba tunachokiongea ni nini. Licha ya kwamba unafanya counseling, mtu anaingia, mtu anatoka. Hata yule unayemfanyia counseling anaingiwa na hofu kwamba labda hawa wamekuja kunichunguza mimi au namna gani. Kweli niwashukuru sana madaktari wangu, niwashukuru THPS ambao kupitia daktari wangu Madina na wengine wote waliweza kunimonti na mpaka sasa ninaishi nikiwa na miaka 62. Asanteni sana.
Thank you. That was just to share how real the situation is. Coexistence of HIV and non-communicable diseases is there, and we need to address it. So our next speaker is none other than my former employer, Dr. Mahesh Swaminathan. He serves as the country director for CDC in Tanzania, leading the agency's broad health programs in the country. Prior to joining CDC Tanzania, Dr. Swaminathan served as the CDC country director in Nigeria from 2017 to 2021, where he led CDC's global health portfolio, including HIV, global health security, TB, and immunization. Dr. Swaminathan also guided the technical priorities, program strategy, and implementation of CDC's HIV and TB programs in Nigeria. Dr. Swaminathan started his career with CDC in 2010 as an Epidemic Intelligence Service Officer with the Division of Global HIV and TB. Division of Global HIV AIDS, DGHA at the time, clinical surveillance team. After his 2-year fellowship, Dr. Swaminathan continued with the clinical surveillance team, which is now a part of the Global Division of Global HIV and TB from 2012 to 2017. He was promoted to lead a team in 2014, where he worked to strengthen HIV case surveillance and other routine surveillance modalities for tracking the global HIV epidemic. Dr. Swaminathan's technical leadership at CDC and within PEPFAR was critical in providing guidance and models for using routine programmatic data for surveillance and measurement of programmatic impact. Dr. Swaminathan received his undergraduate degree in bioengineering from the University of Pennsylvania and his medical degree from Jefferson Medical College in Philadelphia, Pennsylvania. He completed his residency in internal medicine and fellowship in infectious diseases at Mount Sinai Hospital in New York, New York. Please join me in welcoming Dr. Mahesh Swaminathan, who will speak on strategic investments towards integrating NCD services in HIV prevention, care, and treatment.
Great, thank you so much. Thank you to the organizers for inviting me to speak. And also in particular, thank you to the patients who talked a bit about their experience being able to manage both their HIV as well as hypertension. Next slide. So while the next slide is coming up, the previous speakers have talked a bit already about the burden of burden of hypertension. Actually, it's funny. When I started my career, HIV medication wasn't actually that widespread. And over time, my patients, this is true here, what I often say to them now, especially now the medications are easier to take, well, the good news is that you're not going to die from HIV. The bad news is, well, you're going to have all the other problems that the rest of us have, right? So that includes things like hypertension, diabetes. Now our patients have to smoke, have to stop, not they shouldn't smoke, they have to stop smoking, right? And so really it's natural that we can see that there's been an increase in non-communicable diseases among people living with HIV. The data that you see here from the Africa study, which is a cohort that follows, a cohort actually in multiple countries around the world, that follows people living with HIV on treatment, shows that there has been a significant increase in non-communicable diseases, particularly associated with increasing age. If you take a look at the green column, which is men 50 and above, and the purple column, which is women 50 and above, you can see that both men and women living with HIV are, as they get older, are experiencing increases in non-communicable diseases. Next slide. So once again, as we, as those who work in HIV get better at our jobs, we make sure that patients have their virus suppressor taking medication. Now we have to think about, well, how do we help them live well with HIV? How do we make sure that they have both a normal lifespan, but also a healthy lifespan? Once again, we're now talking about, for people living with HIV, the same challenges that people living without HIV have to deal with as they grow older. Next slide. And so now in PEPFAR, through its country operating plan guidance in our fiscal year 23, recommended screening from non-communicable diseases as well as treatment through integrated healthcare models. And that ideally antiretrovirals should be provided in the same place and by the same providers who also provide chronic medication. And by the way, I just have to say that in many other countries, this is the case. So when I was doing my training, for example, in the United States, as a both internal medicine and infectious disease boarded physician, I had to manage my patients' hyperlipidemia, their tobacco use, their blood pressure, and so forth. So this is something that's not really new. Next slide. So CDC Tanzania, we're trying to integrate management of non-communicable diseases in our HIV programming. So for example, blood pressure screening. Now, it's interesting that we're talking about blood pressure screening. I would argue, and I've been pushing this and I'm finally succeeding with our partners, that there's a reason why we call blood pressure a vital sign. Anytime any of us see a physician or nurse or other provider, we must have our blood pressure taken. And so really this is not a huge stretch. This is, not only is this important for diagnosing hypertension, but also just good medical practice. We also have been integrating HPV vaccination for girls living with HIV, and we'll talk a little more about that later, as well as cervical cancer screening and management, including visual inspection and use of acetic acid for treatment. And then finally, facilitating referrals to services for people living with HIV with signs and symptoms of NCDs. And we talk about referral because our program is supported primarily by PEPFAR, the President's Emergency Fund for AIDS Relief, and there'll be a session on that at 4 o'clock. Our funding is primarily for the management of HIV, and so we do have limits in terms of what we can procure to provide services for non-communicable diseases. But that doesn't mean that we can't refer patients, and it also doesn't mean that the programs that we support can't be a venue for patients to receive services in an integrated and safe way. Next slide. So you heard a little bit from Dr. Ola about THPS's work in terms of supporting the screening for nutritional status as well as hypertension among all patients in their regions. This is something that all of our implementing partners will be doing, though, and we'll talk about this later, there are a few places where we may be able to actually procure medication provided. And any of those who are found to be overweight, obese, or hypertensive are then linked to appropriate services. Next slide. So in collaboration with the government of Tanzania, we will be implementing an integration project, implementation demonstration project, integrate hypertension management, not just screening, but management with the prescription of medications in 4 regions and selected facilities from October, starting October 2023. And this will include capacity building for healthcare workers and hypertension management, coordination, supervision, and prevention of antihypertensives. And we're hoping that the lessons learned from this will then inform the national strategy. And I really want to give credit to Dr. Kaushik who really helped us think through how to implement this project. The idea here is that with 2 or 3 antihypertensives that are available in Tanzania and are relatively inexpensive, that the vast majority of patients can achieve well-controlled hypertension. And I have to say that for those of you who are interested, you can always go to the website of Resolve to Save Lives, Dr. Tom Friedland's NGO, which is supported by Bloomberg. And there you'll see that there are many other countries that have actually been able to show that this can be done. Next slide. In terms of preventing cervical cancer, we have already started to support HPV vaccination among girls living with HIV in all regions, in all the regions that we support. We started in May 2022. However, the government of Tanzania is already now taking the lead in terms of really broadening this effort. With support with Gavi, I believe that the Ministry of Health is planning on implementing more wide-scale HPV vaccination in calendar year 2024. And CDC is well poised and their partners to support that effort. What I will say is that I do think Tanzania is in a good place and has the ability to eventually eliminate cervical cancer. I say eliminate because there will be people who are older women in particular who are not eligible for vaccination who've already been infected with HPV. However, now that we're talking about really broadening vaccination, doing multi-age cohorts, we really can make a dent in this disease and really make sure that very few women are afflicted with cervical cancer moving forward. Next slide. And as I've noted earlier, we are working with the government of Tanzania through our implementing partners to support the screening of cervical cancer and the treatment of precancerous lesions. This work should continue, but I'm also hoping that as we move forward with the ambitious scale of HPV vaccination, that this type of work will become less and less necessary. Next slide. So in terms of moving forward, we're going to continue to work with our government of Tanzania colleagues as well as our implementing partners to ensure that non-communicable disease management is integrated into HIV care. And I just want to say that one of the things I think that the HIV program has really done is, yes, HIV is a communicable disease, but HIV is also a chronic disease. And in terms of the management of HIV, it's not simply enough to provide antiretrovirals, but also requires a whole system around that patient in terms of adherence counseling, in terms of encouraging behavior change, in terms of helping people live with their disease, that is not dissimilar to what has to be done when someone is diagnosed with hypertension or diabetes or hyperlipidemia. For example, I was diagnosed with hyperlipidemia a few years ago, and yes, you may not tell, but I am trying to live a healthier life, and I can see that the challenges that I have had are not dissimilar than what people with HIV or people with diabetes need to deal with. That the life that you led before has to change in order to make sure that you live a longer and healthier life. So I'll stop there, and thank you very much for the opportunity.
The last speaker on our panel for today is Dr. James Tumaini Kengia, who works with PORALG, the ministry under the President's Office, as coordinator for research and publication. He is an experienced public health specialist with demonstrated history of working in the hospital and healthcare industry in general. Dr. Kengia is a principal dental surgeon with a postgraduate diploma in hospital management that was part of an international leadership training in hospital management that was supported by the government of Germany by then. He also has an MBA for medical doctors from the University of Applied Science in Germany, a PhD in public health leadership, majoring in healthcare economics from Tokyo Medical and Dental University in Japan, under the scholarship of the Japanese government, mixed scholarship, and a postgraduate diploma in leadership organized by the Uongozi Institute in partnership with Aalto University of Finland. He has also worked as a member of the Regional Referral Hospital Management Team and Regional Health Management Team, and as acting regional medical officer for Mwanza region, and principal investigator and director for Mwanza HIV/AIDS Service Provision Project. While working within the region and PORALG, he has been involved in planning, coordinating, providing supportive supervision, and monitoring and evaluation of health services. Currently, he is involved in teaching as an adjunct lecturer in health systems management for Master of Science public health students at the University of Dodoma. In the University of Dodoma, he particularly teaches planning, organization, change management, resource management, leadership and management, monitoring and evaluation, and introduction to health economics. Please join me in welcoming Dr. Kengia, who will speak about, his topic is Towards Achieving Universal Health Coverage, the government's approaches to ensure sustainability of the treatment and rehabilitation of recipients of care with NCD comorbidities. Karibu Daktari.
Thank you very much, the moderator. So my job is really very small. Building from the previous presentations is actually to link the issue of universal health coverage, some strategies for sustainability, when we are discussing now the issue of treatment and rehabilitation for people living with HIV/AIDS with NCD comorbidities. Next slide. So I'll just talk in those 4 areas, a bit of background of UHC, status of NCD services, in particular at the level of the primary health care, some bit of unfinished agenda, and conclusion and looking to the future. Next slide. So just to have a common understanding, talking about UHC, universal health coverage, we are really interested in ensuring that we have access to all the services, building from the promotive, preventive, curative, and rehabilitative services. But the issues of effective coverage is very important, and of course, guarantee people not to succumb to catastrophic health expenditure is also necessary. Next slide. So you see that as we are discussing on UHC, NCDs, HIV/AIDS, and integration issues, the issue of equity in access is critical. That's point number 1. But of course, the second thing is the issue of guaranteeing the quality of services and financial risk protections. But in most of the cases, when we're discussing about UHCs, usually people overemphasize on the demand side. In particular, we are discussing about UHI, Universal Health Insurance, a lot. But we forgot that as we're discussing about universal health coverage, also the supply side area is also very important. Next slide. So building from Tanahashi chart, the health coverage, at the middle there, we are talking about utilization of services here. The issue of integrated care, that is important. But on the left side there, number 1 there, the availability of services is critical. That is number 1 is important areas, including the issue of HR, qualitative and quantitative, about the availability of staff in our areas, in the facilities, the issue of health commodities and medical equipment as highlighted in previous presentations, but also, as we are talking about equity issues, how our facilities are really located countrywide, that is critical. Then you have the accessibility and initial utilizations, then people will really consume the services towards the adequate coverage, and our interest at the end of the day is to have the quality services, the effective coverage. Next slide. So if we now reflect these models in our healthcare systems, we will realize that it is very important now as we are discussing of integrations and universal health coverage for NCD services and HIV services, the important entry point is PHC, primary health care. That is critical. And the second, why? Because this is like a quick win among the other options. There's a lot of evidence. If we can enter through PHC, we're able to have a larger impact. Next slide. So why we are talking about PHC is because really more than 95% of health facilities in Tanzania are really coming from the PHC levels. We're talking about from dispensary to the level of the district hospitals. But of course, at the base, in Tanzania healthcare system, there's a community, which is also within the PHC, the local government authority there. Next. That's the 95%, the PHC. Next slide. So if now we look into the primary care in Tanzania, trying to explore the landscape in terms of the provision of services, you realize that out of those facilities that are operating nowadays, 793 by September, we have 278 health centers have established NCD clinics. I think just back the previous slides. Yeah, this one. So out of those facilities, 7,015 public facilities, we have a number of them which are public, around 6,000. But of course, we also realize the importance of private sectors as part and parcel of the PHC. But as a key takeaway message for the district hospital now, out of all those 173 district hospitals, all are also having the NCD services. But out of 173 district hospitals, we have 67 district hospitals that have a dedicated diabetes and hypertension clinic that is provided once every month. And also with 8 district hospitals that have started sickle cell disease clinics. So you can see a couple of kind of opportunities for the integration of services, because we already have those kind of services. The next slide. So for the health centers, the status quo to date is we are talking about 278 out of 793 health centers. They have established NCD clinics, mainly diabetes and hypertension, and we have registered around 1,287 clients that have been so far registered in these clinics. But also there's a screening for hypertension, diabetes in pregnancy that is conducted in the level of the health centers. But if you go to the dispensary level, it's a bit limited because of the availability of staff and the likes, but mainly the screening for hypertension and diabetes in pregnancy is available, but no specific NCD clinics. But testing for diabetes and hypertension is conducted at OPD, especially in urban setting facilities. Next slide. So human resources also, if we look into the landscape of human resources, in terms of now we are discussing about integration of services. The good news is, if we reflect back to Tanzania's care systems 10 years ago or likes, maybe we will miss the medical officers and nursing officers in the health centers. But nowadays, at least all the health centers, you will have at least one medical officer. Even in the most rural area in Tanzania, we have placed some medical officers there and nursing officers. So those are some of the opportunities for integrations because of the capability in terms of the skills and likes. And in addition to that, with Tanzania Diabetic Associations, a total of 2,778 healthcare providers from 702 health centers have been trained to provide NCD services. That is our additional qualities when we are discussing about integration of services. And the other things that financial resources is important, but the good thing that is also an opportunity within our planning tools, the CCHP, Comprehensive Cancer Health Plans, and also the facility plans. We have a dedicated priority areas for non-communicable diseases. Priority area number 4, and of course, for the infectious disease, communicable disease, priority number 3. So those one, we are able now to budget some of the issues. And of course, at the level of the facilities, with the health facility plans, we are now also directing the resources, the financial resources, to the level of the facilities, the health centers and the dispensaries. That means we also are able to plan and accommodate some of the resources for the implementation of the interventions that we're talking about. Next slide. So what are the unfinished agenda as we are discussing, also reflection with the previous presentations? I think we also need to have some kind of a common understanding and agreement building from the previous studies that came out, like Respond Africa and the like. They've shown already that integration of services is important, but also a need now to build from that one with the upcoming also implementation research kind of, that was also talked by the CDC directors, all those one. We then have to come up with a common understanding about the model operandi when it comes into the integration of services, the how part. Of course, we also need to embed some implementation research to have more understanding while we're also implementing, to build a very stronger evidence, come up with the proper guidelines that is standardized countrywide for the implementation, and of course the capacity building, and then come up with the implementations. Next slide. So in conclusion, and looking at the future, talking about integration of services, we cannot forget about the PHC. It's critical here, the primary care as an entry point. But of course, we cannot forget the universal health insurance bill, the discussions. That is very important because there's also a demand side intervention that is needed in terms of the ability to pay and the likes. Improvement of quality, we cannot further ever emphasize on it, but effective referral system, but also the issue of enhancing data use and research for decision making is important. But lastly, but not least, is the issue of people-centered healthcare. We are talking about integration of services. Next slide. But we also need to overemphasize on the needs of the promotive and preventive services. Because people, when they are coming to the healthcare facilities, they are ants in the communities without any kind of illness. We need to go there and close the tap so that we do not have people come in the facility with already illness. And we also emphasize also the need not only of the community, but we should not forget ourselves as healthcare workers. That is important under the concept of people-centered healthcare. Next slide. Asante sana. Thank you very much.
Thank you so much. At this juncture, I'd like to invite our 5 speakers to kindly take a seat up front so we can engage in the Q&As and discussions. Thank you so much all for the insightful presentations. We've gone through the basic sciences, the understanding of the situation in Tanzania, what is happening at the site level. We've heard a little bit from some recipients of care. We've heard about the development partners' vision in terms of investments, as well as the local government approach. Karibuni, please. Please raise your hand if you have a question or a comment relating to this topic, so you can get a microphone sent to you. Do we have another one in the room? Let's start with 3 questions, and then we'll take some responses and take another set. So sitting up front is an advantage. 1, 2, 3.
Thank you very much for very nice presentations and very nice topics. My name is Chako Halfan. I'm basically an oncologist. I have one interest, and my interest is how we define primary healthcare in our settings. Because from the presentations from my colleague there, it seems even the district hospitals, the health centers, and all the primary health care. But when we compare in other parts of the world, for example, maybe UK, the primary health care is where a client is first seeking a medical care. And can be a family physician at the family level, or can be a nearest health facility that a person can go, that the primary, the lowest referral of the healthcare. But me being oncologist in the past, for example, you can find a person who has been dispensed before being diagnosed with the disease, maybe 6 times. Then you refer to health center for another 3 months, then to hospital, spend another maybe 3-4 months, then regional hospital, then Muhimbili, then to Ocean, actually spend like 3 years. My advice is we need to refine our primary health care. Otherwise, we're going to face a big problem in the future. If we consider hospital, which is maybe in the 3rd level of the referral system, is the primary health care, that's not the primary health care as far as it's concerned. My thinking is maybe a family, those people, what we call healthcare workers, those community healthcare workers, probably in dispensaries, we can define them as primary healthcare, not health centers, not district, not regional hospital, or not even the national referral hospitals. Thank you.
Patrick.
Thank you very much. I'm Patrick Kinemo. I work for Pathfinder, Tanzania. I have a question, and probably picking from Dr. Chakuo here, just to really tease out and ask what more can we do? So we know that we have a limited human resources for health, but what more can we do? What opportunities are there for things like task shifting to the community workers to perhaps at the community level, issues of repeat prescriptions, perhaps having patient group care directions, protocols which can be used by these lower cadre of what more can we do, or what is being done now and what more can we do? Thank you.
Thank you. I'm Matthew Kawogo. I come from the National Council of People Living with HIV. Thanks for the good presentation, the last presenter in particular. I'm concerned about sustaining healthcare services, particularly primary healthcare, with the fact that we at large depend on donor funding, which recently we see diminishing. If I take statistics from the AIDS Trust Fund, 2 years ago, it looks like still over 95% of the funds for HIV is coming from the donors. And we are seeing the funding going down. I think Doctor from CDC can prove that. So how do we connect sustaining primary health care services with the resources diminishing and the fact that we are depending on donor funds? That's number one. And number two, if I'll be selfish, then what's the best way of engaging in the communities, particularly people living with HIV, in addressing some of the non-communicable challenges which are non-medical? We know that they have a role, and what do you advise on that? Thank you.
I'm made to understand we only have one microphone, so I'll take two more questions. I saw Mariana and another hand at the back.
Thank you very much. I'm Mariana Balampama. I work with PACT as Deputy Regional Director for Africa. Mental health conditions have also been mentioned as an important comorbidity for people living with HIV, but I haven't heard as much in terms of what is being done and what can be done. I would love to hear from the speakers, in particularly Dr. Kaushik and Dr. Ola, from an implementation perspective. How is mental health being integrated into care for people living with HIV? Thank you.
Thank you. My name is Dr. Caleb Joel. I work for MST as a System Strengthening Manager. And I would want to congratulate THPS, CDC, and PEPFAR for the special interest for the people living with HIV and NCDs. And my worry was some of our facilities which we are supporting are dispensaries. That means they are deprived of the human resources and the capacity to diagnose as well as manage the non-communicable diseases, especially diabetes and hypertension. So what are we doing to ensure that the client who is at the primary health care get the best management on top of the capacity which is available, and we are not imposing him with an extra cost on buying the medications which are now not being supported under any VETCO program? Thank you.
Thank you so much. I'll now invite our panelists. Dr. Ola, would you like to start?
Thank you very much for the questions. I think I had two. One on mental health. Yes, we as THPS realized that mental health is important among people living with HIV. And when we started our efforts to integrate NCD services, we also considered that. So, but we decided that we'll have to start with what we felt it was easier to start with hypertension because, as Dr. Mahesh mentioned, blood pressure is one of the vitals. So we felt that there was no excuse for people not being taken blood pressure as a vital. But we realized that we need to expand the scope of the non-communicable diseases that are offered are integrated at the CTC. So when we provided the training to the providers on NCD management, we include mental health management as part of their training. So that's one. And on the question on what are the best ways to manage the people living with comorbidities without adding more cost to them. Yes, we understand that as one of the barriers, and us as THPS, when we started these efforts to integrate the services, we are asking ourselves, we'll identify people with these comorbidities. What will we do to them? What if they cannot manage this, afford to pay for this other management? So we are also thinking of how to be able to do it. One of the options that we are considering is to encourage majority of them to join the health insurance packages that are available as one way of handling that. Thank you.
Thank you, Dr. Ola. Dr. Mahesh, did you have anything that you'd like to comment on?
Yeah, thank you. I think that maybe I'll just speak to the issue of staffing and sustainability. I think that there are a few things here. I think one is Dr. Ola did mention the importance of insurance schemes. One way to ensure that there is money and funding available to support, for example, the procurement of medication and the paying of providers is to have some type of universal health insurance of some sort. And so I know that the government is thinking through how to set up those schemes, but I think from a revenue standpoint, I think that's really critical. But I think the second thing, though, is really thinking through how services are delivered and by whom. One of the things about medicine is that medicine, in my view, has resisted a lot of the productivity gains that other industries have experienced, right? So, for example, if you take a look at, many of you have smartphones. If you compare that to the phone that you had, let's say, 8 or 10 years ago, in fact, the phone you have is certainly more powerful than the computer that I had when I was 11 years old. And medicine has resisted that in part. And I think in part it's because we still haven't adopted more efficient ways of providing services. And one of these areas I would say, particularly for medical doctors, is that our role may have to move away from, yes, we still have to provide direct patient care for patients with complex diseases, but maybe much of our work should at some point move to supervising community health care workers and nurses who are providing medical services for diseases that have significant morbidity and mortality, like HIV, hypertension, but maybe those cases aren't that complex. For example, now with HIV, one pill once a day is enough to suppress viral replication, and the side effect profile of that one pill is actually pretty minimal. In regards to hypertension, we know, and we're going to demonstrate this in Tanzania, that essentially maybe anywhere from 1 to 2, maybe 3 drugs at most are needed to control hypertension in the vast majority of people. And those medications don't really have that many side effects, and those side effects are ones that are easily identifiable. Things like lightheadedness and so forth, or can be identified through laboratory results, which once again, the physician or other provider can review without necessarily having to see the patient. So I think that when we talk about productivity and we talk about sustainability, the role of physicians changes. That doesn't mean that physicians are not a key part of the healthcare system, but our role may be that we see patients with complex conditions that can't be managed by somebody else, and in the meantime, we are also managing large groups of community healthcare workers, nurses, and so forth who are providing services, let's say, in the community. Thank you.
Karibu, Dr. Kengia.
Thank you very much. So I'll talk in two. The first one was the issue of sustainability. That is a very important area, and I think, in my opinion, is we can take care of it in 2 ways. Number one is we are now discussing about integration of services and even the issue of promotions and preventive services in order to cut costs. That's number one. But number two is if you look into National Health Account of Tanzania 2020, then you realize that, yes, the donor fund is decreasing, but we also, the domestic funding is increasing, if you check that report. But the problem of that report is the domestic fund is increasing is really not within the health insurance envelope. Is the cost, they just pay the cash. So that the problem that the people could succumb into catastrophic expenditure, that's the problem. So the only way is really to increase the pool of the prepayment mechanisms so that we can have a pooled fund that will be utilized for financing the health sector. And when it comes to the question about the PhD definitions, yes, I agree that the first point of entry should define the PHC. But now if you go into Tanzania's care systems, really people will go to the nearby facilities. And with our current landscape, sometimes the first or the nearby facility could be centers or dispensaries or disc hostels. Probably with the matured health system of Tanzania in the future, if we have a guarantee point of entry, the nearest to the populations to be a dispensary, then we can redefine. I think it's something that we'll keep on discussing. Asante sana.
Before you move, Dr. Kangia, there was also a question about human resources for health limitations and how that might impact integration of NCD care. Do you have thoughts about the idea of task sharing, task shifting?
I think that we have already the guideline for that one. So with utilizing the guideline, then we can invest upon that guidelines. But of course, also the Minister of Health currently is also moving towards involvement of the CHWs. So there's ongoing discussion on the curriculum in terms of the package of the issue that the CHW will do. So we can also think about accommodating some of the issues that will be done by the CHWs. But also with the ADO, there's some evidence. For example, there's Afya Tech projects that is being done in Kibaha. What they do is really they provide a linkage between the ADO shop and the facilities. So some people with some of the issues, like if they go to the facilities, then the ADO could really do something. So it's also an area that is still under discussion to see how best you can also utilize those people to improve the services.
Professor Kaushik, karibu.
Yeah, thank you very much. I'll start with the first question regarding the primary care. I think primary care within our settings would probably be at a health center level, because at the dispensary level, I think still we need to build the blocks here and we need to get that access. The problem at the dispensary level is that there are more than 6,000 dispensaries. And then even if you are going to impart training and provide equipment and support, it's going to be it is going to take some time. But then at a dispensary level, I feel that it should be the promotion and prevention which should be the focus. And I think from there, with an outreach by the community health workers within the community around the dispensary should be our key, basically, way forward, going forward. So I think we need to get those community health workers. The problem with the community health workers just now is that there are community health workers, but they're dependent on projects. They are not systemized. And because they are not within the system, whoever pays them more is the priority, you see? So that you might find that a poor program might not be able to sustain the community health workers because the payment required is high. So I think first we need to streamline the community health workers task force if we want to go for prevention. Second thing is that we need to link them to the dispensary, and then from the dispensary mainly work on early diagnosis and then referral to the higher levels of care. Second thing, I think the advantage of the HIV program, which we have learned from the TB and HIV program, is the tracking. I think they've got a vertical tracking system, and they've got a unique identity number. Within the NCDs, we do not know how many people are hypertensive, how many people are diabetes, because today I might go to one facility, I'll be registered with a different number. I'll go to a next facility, I'll be registered with a different number. So you might find that there is a lot of duplication. So and we do not know what's happening to them, because you can't track them. So even if you want to track them and do a longitudinal look at what is happening, unless you are in a study environment, you are not able to track them. So I think what is important is that somehow Ministry of Health and the local government need to come up with a system whereby all these NCD cases have a unique identity number. So wherever they go, they can actually link to those numbers, and then only we'll be able to actually change the outcome. Third thing is, if we are going to do task shifting, we need to have very simple protocols of care. And as Mahesh mentioned, that I think we need to not start with a Mercedes-Benz, we need to start with a Volkswagen, and we need to start with amlodipine, because if you come to amlodipine, they say, amlodipine ini dawa ya zamani, tumia hiyo. But basically, amlodipine still works the best, you see, within the hypertension if you are starting step 1 therapy. So within hypertension, if step 1 is a diuretic, second one is a calcium channel blocker, third one is probably an ACE inhibitor or a beta blocker. And those if you look at the calculation, it does not cost you more than $60 for a person for a year for the entire hypertension treatment. So I think what we need to be is to be cost effective, but at the same time, make sure that the quality of care which we are providing is at the optimum. Thank you.
And Dr. Mary, we have 2 minutes left.
Well, thank you very much. I didn't have any specific question addressed to me, but I'll come back from the comment from the epidemiology point of view. The first one is really the need for data, as I think there was a session earlier that we were told how the planning and how the resources are allocated, and I think also Dr. Kingia highlighted on that a little bit what they use. So they need all this prevalence data to be able to plan for services across the health system. So I think what we need to do also in terms of integrating, we need to also integrate our data system. So within the routine national surveys that you do, you might need to also include NCD indicators, and also within the main NCD surveys to also include some indicators from all the other programs, so that we are able to link the epidemiological trends of these different diseases. But also in terms of prevention, we had a lot of discussion earlier on when we said the advocacy around NCDs with Professor Kaushik. You have nice linkages in terms of multisectoral linkages within the HIV programming and the national coordination mechanism that we're actually very, very jealous of, when they were like, is there possible to extend that multisectoral coordination so that we can also, because you need the same structure to address NCDs in the country, and we haven't been successful. I think it's because of also the funding mechanism is, it was a bit of a challenge. So I think that for us at a national level in terms of addressing NCDs on a larger scale, it's a platform that probably we could leverage to make sure that we address NCDs in the country. And I would also like to take you back to the slide that also Dr. Kingia showed us. I hope you saw the triangle, that we have more actually health facilities at the lower levels and fewer at the higher level. I can tell you in Tanzania, the prevalence of hypertension is about 30%. So if you, the adult population from 25 and above, we have a lot of patients, but they have only 1,200 patients at the health center. So we need to flip that to make sure that we strengthen the primary healthcare facilities to make sure that majority of our patients, majority of our services are actually provided at the lower level of care. So we need to flip that. And we can only do that through system-wide strengthening, and also looking at the 6 pillars of the health system. So it has to be looked in that way. We shouldn't verticalize it, but because at the same time, it's this same patient that will go to the health facility with all these multiple problems. So we need to integrate that within our programming and
Thank you. We are
systems.
out of
Thank you.
time. Thank you all for making time to attend this health forum. We hope it was helpful, it was informative to you, but it has also stimulated thinking around how best we can start addressing the challenge of non-communicable diseases as we also address HIV and AIDS. Thank you so much. I'd like the panel to kindly stay for a group photo. THPS team, karibu for a group photo up front. Group photo, THPS.
It's lunchtime now. As you leave, you remember it is Kilimanjaro, hall third floor.